Good afternoon, my beloved students. Welcome to the lecture from Department of Psychiatry. This is Dr. Mohammad Shafiul Islam Khaled, Associate Professor, Department of Psychiatry. My students, you know, the whole world is the massive stress. So today I am going to discuss one of the stress-related disorder, that is somatic symptoms and related disorder. So before I going to enter the class, I would like to share one of my experience. That is, day before yesterday, I have visited a patient, a girl of 24 years, come from the rural area with right-sided weakness, severe seizure, which is prolonged and hourly 5 to 10 times, and blurring of speech associated with the impairment, the coordination of her limbs. Initially, I talked to the patient caregivers and the patients, then going to physical exam and neurological exam. There was no abnormality revealed on her physical and neurological exam. Then I have sent some investigations like MRI of the brain, EEG, some baseline investigations like CBC, urinary, TSH, electrolytes, but there is nothing abnormality detected in her lab findings, lab investigations. I have treated her just only anxiolytic and again tried to talk to her. So later I discover there was some story behind the disease, and she shared me just 1 week back. She was alone in her home, and she observed her father has stolen a cell phone from the neighbor's house, and this thing make her so stressed and so pathetic, so shocked. Then she can't share anyone, and after then she developed these kinds of problem. Then I talked to her about the points or against the point of her the story, and give some antidepressant. And finally, the patient has left the hospital with her own leg without any helping of other hand. So have a look. Now come to the topics. The term somatoform derives from the Greek soma for body. The somatoform disorders are a broad group of illness, have bodily signs and symptoms as a major component. These disorders encompass mind-body interactions in which the brain, in ways still not well understood, sends various signals that impinge on the patient's awareness, indicating a serious problem in the body. Additionally, minor or as yet undetectable changes in neurochemistry, neurophysiology, and neuroimmunology may result from unknown mental or brain mechanisms that cause illness. So 5 specific somatoform disorders. There's a somatic symptoms disorder, conversion disorder. It's another name is functional neurological symptom disorder. And basically, conversion disorder is widely used. Previously, it has been told, someone told hysteria, and many more terms. But now it is a widely used term is conversion disorder or functional neurological symptom disorder. You have found a lot of case in your practicing life, even the hospitals. The illness anxiety disorder, and the last one is the factitious disorder. So now I'm discussing about the most potential and the most widely used disorder, those you are finding in your practicing life, that is the conversion disorder. So what is conversion disorder? A conversion disorder is a disturbance of bodily functioning that does not conform to current concepts of the anatomy and physiology of the central and the peripheral nervous system. It typically occurs in the setting of stress and produces unconsiderable dysfunction. That means when any when any stress is converted into physical symptom, then it is called conversion disorder. Simply, I am telling, suppose anybody is come with a huge stress, like those girls having stress because she observed her father has stolen a mobile, and she felt guilty that why her father is doing this, but she can't share anyone, so she develops some kinds of physical illness. So these are the one kinds of conversion disorder. DSM defines conversion disorder as characterized by the presence of one or more neurological symptoms like paralysis, blindness, and paresthesia that cannot be explained by a neurological or medical disorder. Now, symptoms. Some motor symptoms I would like to share, that is involuntary movements, tics, torticollis, seizures, abnormal gait, opisthotonous, falling, paralysis, weakness, and some sensory deficit. That is the anesthesia, especially of extremities, midline anesthesia, blindness, and deafness. Some visceral symptoms also be found, that is psychogenic vomiting, pseudocytosis, globus hystericus, syncope, urinary retention. Now the epidemiology. The ratio of women to men among adult patients is at least 2 to 1 and as much as 10 is to 1. And now if I discuss the data which indicate that the conversion disorder is most common among the rural populations, persons with the little educations, those with the low intelligence questions, those in low socioeconomic groups, military personals who have been exposed to combat situations. Conversion disorder is commonly associated with comorbid diagnosis of major depressive disorder, anxiety disorder, and schizophrenia. And you noticed first time I have discussed one lady or one girl, I have considered anxiolytic medicine because she came with some neurological problem, but she also had some anxiety problem like palpitation, restlessness, sleep disturbance. So I have considered anxiolytic medicine. So again, I'm telling the conversion disorder is associated with some disease, that is the major depressive disorder, anxiety disorder, schizophrenia. And some the associative features, that was the primary gain and the secondary gain. So what is primary gain? Primary gain is her stress when convert the physical symptoms, that is the primary gain. Like patients achieves primary gain by keeping internal conflicts outside their awareness. Symptoms have symbolic values. They represents unconscious psychological conflict. And now secondary gain. Secondary gain what? Secondary behavior gain means attention seeking behavior. Like patient acquire tangible advantages and benefits as a result of being sick. So if I simplify the primary gain and secondary gain, that is the primary gain means convert physical convert the stress in the physical symptom, and secondary gain means attention seeking behavior. The simple thing. Now come to the management. So before going to management, you have to go through details about the physical examination and neurological examination. Even you go through the laboratory investigation, because without these two things, you can't say the patient is suffer from or conversion disorder. You have to make sure that the patient has nothing problem from this his lab diagnosis and other physical examinations. So for management, we have started the obtain medical and psychiatric history from patients or from informers. Carry out appropriate medical and psychiatric examinations. Arrange investigation for physical cause. Reassure the patient and attendant. Arrange investigation for physical cause. That was I discussed. The like he has the if she has or he has the palpitation, so you have to go through the thyroid function test. If the patient have impairment of the limb or weakness, then you have to go through the MRI. If the patient came with the seizure, then you have to go through the EEG. So this thing must be noticed. Then reassure the patient and the attendants. Basically, in our perspective, a lot of patient attendants, caregiver, unnecessary come to the hospitals or cabin and make rush, and doctors cannot easily handle the patients. So before going to handle the patient, just leave them out with a gentle manner. Then keep the patient quiet and very sound conditions. And after then, we reassure the patient that no problem. This problem is not huge. Come to our hospital and all are curable. Then it's a kinds of reassurance. Even we can give the reassurance to our family member also. Then avoid reinforcing the symptom or disabilities. Sometimes patient's family members are too much enthusiasm and too much caring to the patient, and 4 or 5 persons are forcing the patient. So this thing should be avoided. That's why we keep the patient alone, or a single family member, or remaining live outside. Offer continuing help with any related psychiatric and social problem. That means if the patient have any other psychiatric problem like depression, then we are going to the antidepressant medicine. If the patient has anxiety, then we go through the anxiolytic medicine. If the patient has psychosis develop, then we can give the small doses of the antipsychotic. Even sometimes we can give the social problem. Now the another portion of the somatic disorder, that is the illness anxiety disorder. So what is the illness anxiety disorder? Illness anxiety disorder entails preoccupations with having or acquiring a serious undiagnosed medical illness. A thorough evaluation fails to identify a serious medical condition that accounts for the individual concern. While the concern may be derived from a non-pathological physical sign or sensation, the individual's distress emanates not primarily from the physical complaints itself, but rather from his or her anxiety about the meaning, significance of the complaint. If a diagnosable medical condition is present, the individual's anxiety and preoccupation are clearly excessive and disproportionate to the severity of the condition. Individuals with the illness anxiety disorders are easily alarmed about illness, such as by hearing about someone else falling ill or reading a health related news story. Their concerns about undiagnosed disease do not respond to appropriate medical reassurance, negative diagnostic tests, or benign course. Individuals with the disorder often examine themselves repeatedly. The research their suspected disease excessively, like on the internet. They generally have elevated rates of medical utilization but do not utilize mental health service more than the generation population. They often consult multiple physicians for the same problem and obtain repeatedly negative diagnostic test results. Now, the another portion of the somatoform disorder is the factitious disorder. Falsification of physical or psychological signs or symptoms or induction of injury or disease associated with identified deception. The individual presents himself or herself to others as ill, impaired, or injured. The deceptive behavior is evident even in the absence of obvious external rewards. Methods of illness falsification can include exaggeration, fabrications, simulations, and inductions. While a pre-existing medical condition may be present, the deceptive behavior or induction of injury associated with deception causes others to view such individual as more ill or impaired, and this can lead to excessive clinical intervention. Malingering. Malingering is actually differentiated from the factitious disorder by the intentional reporting of the symptom for personal gain, like money, time of work, etc. In contrast, the diagnosis of the factitious disorder requires the absence of obvious rewards. Now we are going to discuss the pain disorder, which is the another portion of the or part of the somatic disorder. In DSM defines pain disorder as the persistence of pain, that is, the predominant focus of clinical attention. Psychological factors play an important role in the disorder. The primary symptom is pain in one or more sites that is fully accounted or by a non-psychiatric medical or neurological condition. The pain is associated with emotional distress and the functional impairment. Thank you, my dear friends. Actually, it's a very small chapters, and I hope if you have any query or any questions, don't hesitate to write in the comment section. I try to give the answer later. Thank you very much.